ChatGerry, self-assessment of my self-studied medical knowledge, position, and longevity focus, number 1481, VPT Sharp 042, December 27, 2025. Gerald C. EclaireMD Foundation. Category, General. Preface, I am not a physician, and I do not claim the authority of a licensed clinician. My formal training is in mathematics, physics, engineering, artificial intelligence, and corporate leadership. Over the past 4 decades, beginning in 1986, I have lived with 4 metabolic disorders. These included progression from overweighting to obesity and later a return to normal weight, diabetes, evolving from sustained hyperglycemia to stabilized normal blood sugar, mild dyslipidemia, and occasional episodes of acute hypertension. During this time, I experienced 9 mortality-related medical events over a 31-year span, from my first heart attack in 1994, to my most recent stroke in 2025. This background defines why and how I learned medicine by myself. Introduction. My medical learning did not begin as an intellectual pursuit, it began as a survival requirement. After living through obesity, diabetes, 5 cardiovascular events, chronic kidney disease required dialysis treatment, foot neuropathy near amputation, retinopathy, with risk of blindness, and most recently, a hemorrhagic brainstem stroke with an estimated 79% to 80% mortality risk, I realized that understanding disease only at the moment of diagnosis is fundamentally insufficient. Since 2010, I have devoted the past 16 years to intensive and continuous self-study of pathophysiology, spending about 14 hours each day on this work. I studied independently, without institutional affiliation, professors, classmates, or patients. This solitary approach allowed deep conceptual understanding, although it sometimes limited my familiarity with clinical pronunciation. My learning was driven by necessity, not academic ambition. Over this period, I read more than 10,000 medical papers, and published 1,480 research articles focused on mortality diseases I personally experienced. Through this process, I became aware of structural limitations in how modern internal medicine is organized. Many specialties rely heavily on statistical methods, designed for population averages. These tools are essential and effective, but they are less suited for examining long-term individual trajectories, outlier cases, and multi-decade cause and effect relationships. Chronic diseases do not appear suddenly. They develop quietly, through continuous metabolic stress and cumulative damage. These long developmental processes are often underrepresented in conventional studies. This realization shaped the direction of my research, and led me to study disease as a continuum mechanics system that evolves over time. Where I stand relative to clinical doctors. Clinical doctors are trained within a well-defined and essential framework. Their strengths include diagnosis, guideline-based treatment, medication management, acute decision-making, and crisis intervention. They work under time pressure, legal responsibility, and population-based evidence. These skills save lives every day, and I respect them deeply. My knowledge profile is different, because I work outside that existing structure. In chronic disease progression, long-term causality, and systems pathophysiology, my understanding is comparable to, and in some areas, deeper than, the average internal medicine physician. This difference does not come from superior intelligence. It comes from working on problems most clinicians are not structurally trained and positioned to address: multi-decade trajectories, silent vascular damage, cumulative energy buildup, and irreversible deformation before symptoms appear. Where I differ most is longitudinal reasoning. I analyze disease as a continuous process, not as isolated clinic visits. I focus on the years between diagnoses, when lab values may appear acceptable, while internal damage accumulates quietly. I think in terms of strain, rate, flow stability, and cumulative stress, not thresholds alone. A concrete personal example of blood pressure. After my hemorrhagic stroke on June 21, 2025, triggered by acute hypertension after more than 36 years of diabetes, I began collecting blood pressure data at an unusually detailed level. Since August 2, 2025, I have measured my blood pressure daily, using validated upper arm and wrist devices on both arms. I record about 16 measurement sessions daily, capturing SBP, DBP, heart rate, and calculating pulse pressure and mean arterial pressure. Between August and December 2025, I collected 11,769 data points. I adopted this approach because blood pressure fluctuates at the highest frequency. Among other common biomarkers, capturing such behavior requires dense sampling, sustained persistence, and deep understanding of physiology. This level of detail is rarely feasible in clinical practice except ICU patents, but it is essential for searching longitudinal insight. Longevity is another non-clinical example. Longevity is not a clinical specialty. Medicine is optimized for treating disease after it appears. Longevity requires understanding how multiple damages are reduced. before diseases exist. Rather than chasing extreme fasting or aggressive interventions, I focused on daily behaviors that are measurable, sustainable, and physiologically grounded. My goal was not optimization, it was system stability. In 2025, my average fasting window remained near from 14 to 15 hours with minimal volatility. Sleep gradually stabilized around 7.5 hours with high consistency. Daily walking averaged about 10,000 steps, not for intensity, but for continuity and flow. Individually, these behaviors are modest. Collectively, they reduce strain rate. Sufficient quantity and persistent effort are essential to reduce the rate of strain change. Over time in mortality diseases, a lower strain rate, in turn, reduces the total energy associated with all forms of mortality disease. Autophagy does not require extremes. It requires repeatedly giving the body enough rest and metabolic space to perform internal maintenance. Longevity is not about eliminating damage. It is about slowing irreversible damage accumulation. Conclusion: I do not see myself as a clinician. I see myself as a scientist, systems medical researcher, and chronic disease process analyst. Doctors save lives during moments of crisis. My work focuses on understanding the long, quiet processes that lead to those crises and how to slow them down from the foundation level. I do not compete with physicians or seek authority. My motivation is personal and ethical. Having survived multiple near-death events, I have seen the fear and worry in my loved ones' eyes. I believe that if I understand something that can help others reduce suffering and preserve life, I have an obligation to share it clearly and honestly. That is why I chose to use mass communication channels, such as YouTube and Amazon ebooks, to reach people in need, wherever they are in the world. I work in a fundamentally different dimension, scope, and time frame. That distinction defines both my role and my purpose. Disclaimer: I write this article not for fame, but to share what I have learned, so others can understand complex systems, prevent failure, and live better lives. This content is for educational reference only, and does not constitute medical advice. No doctor-patient relationship is created. You may share this article freely, but it must not be altered, edited, or republished as your own. All intellectual property rights belong to the author, Gerald C.